So, hi everyone. Today we are going to talk about bone targeting radiopharmaceuticals. Traditionally, I gave the diagnostic bone agents separately to the therapeutic agents, but in this week I decided to rather throw them together because they all work on the same mechanisms and it just makes so much more sense. So that's why also the lecture is a bit late. I sent it only yesterday because I did quite a considerable expanding it, but also making it more concise. So it's not like a bigger lecture, but it's just having a bit more information in a shorter time period, which is my new goal in life, to give you as much information in as short a time as possible. That's why I also upload these on YouTube, but you can go watch it in your own time. So you don't need to make notes and those kind of things. So bone targeting radiopharmaceuticals is so much more than bisphosphonates and technetium. So let's get cracking. There is different bone lesions in cancer bone metastases. Now I know bone targeting radiopharmaceuticals are also used for injury, maybe small fractures. You can see a fracture or a start of a fracture or a hairline fracture already very much in advance before you can see it on regular X-rays or CTs or those kind of things. So it's really also used for that. Sport injuries, maybe in even in cases where you want to see in infants if they've been abused a bit, or that you can also use these traces for those kind of scans. And then also sometimes for infection imaging, if you look at the differences between soft tissue accumulation as well and the blood flow compartment. So I'm not going to go into all of that, but I will be focusing on cancer bone metastases because I think you can actually see a lot from the mechanism. So this is the mechanisms how these bone tracers accumulate. And there is different types of cancer lesions. It's really important to note. So you get your osteolytic cancer, your osteoblastic cancer, and then mixed. And in most of the cancer types is actually a form of mixed. So it's not that you just have osteoblastic or osteolytic. You can have mixed lesions in, for instance, breast cancer, but also sometimes in prostate cancer and all of the others. But traditionally, this is how the groups are sorted. So then you have to understand how these radiopharmaceuticals accumulate and which ones would you use for the types of cancer metastases that you're investigating. It's really important because if you go further into therapy and you want to give bone-brain palliation, you will not be able to give certain radiopharmaceuticals that fall in the osteolytic cancer types because it should be osteoblastic lesions, mostly treated for bone pain palliation. So yes, bone pain palliation mostly goes to prostate cancer patients or other osteoblastic lesions or mixed. But if you have a breast cancer patient and you want to give them bone pain palliation, you have to make sure that they have some osteoblastic lesions in their metastatic makeup. So bone homeostasis is the difference between bone formation and bone resorption, and this often is in balance. That's why it's called homeostasis, I guess. So you have your osteoblasts that form your bone, and you have your osteoclasts that resorb your bones. And if this goes out of sync, then you get either osteoblastic lesions where there is increased bone formation, there is an increase in excretion of osteoblastic factors, and all of these signaling factors from your cancer, and this builds up your bone more than it breaks it down. And in osteolytic, it is increased bone resorption compared to formation. So when osteolytic lesions are formed, you will also get a high amount of hydroxyapatite and calcium crystals that are open, and then your radiopharmaceuticals can interact with these. So sorry for this picture. It's not really osteolytic, but it was the best one that I could find. I think it serves its purpose. And just to show you on a CT scan how this would look, osteoblastic, it's a lot denser, and then osteolytic is mostly like a less contrast or like a darker area. Also, then the opposite, of course, is true. Sometimes if you do MDP technetium scan and you have an area that is less, so maybe there's a lot of highlight around, but then there is a dark spot on your or nuclear medicine scan, that would be maybe an indication of an osteoblastic lesion, where your your osteolytic lesions. So it's the same. Your osteolytic lesions will be a dark spot and your osteoblastic lesions will be highlighted. So that's how you can also see it. But for traditional ways to see this differentiation, you will have to go for the hybrid scans that will show this. And that's why you have to look at the CT or whatever hybrid scan you are doing. So that's where I come to diagnostic imaging. You have different specificity and sensitivities, and I think you should know this. So scintigraphy, you have maybe a less specificity and sensitivity, but it's really useful, it's cheap, it's readily available, and you can use it and do a lot of patients. So there's a high patient throughput. For most of the time, this is adequate, and then your CT low dose have a less sensitive but more specific, and then you have your MRI, of course, which is not so widely available, and then you also have PET that you can look at FTG. Okay, great. So you have to match the imaging choice with the disease profile. So if you want to just look at bone morphology, therefore osteoblastic and osteolytic, you can do CT or radiography, just normal X-rays, I guess. And in bone metabolism, you start looking at SPECT, maybe FTG. Also, if you want to see marrow involvement and diffusion, you will go to MRI, and then you can also have your combination. So this is really important. Glucose metabolism, of course, is your FTG, and in there you look at how active these lesions are metabolically. So we will have to look at all of these radiopharmaceuticals as we go along. So tying back into the osteoblastic and lytic and the type of cancers that you can use which radiopharmaceuticals for, we have to focus on prostate cancer and then mixed cancer like breast cancer, some lung cancers, and carcinoid cancer. So you need to do a scan, a diagnostic scan, before you do therapy that would indicate that you clearly have osteoblastic lesions that you can treat. And then you can use some of these radionuclides that are useful for bone pain palliation. So phosphorus 32 was the original, I want to say OG of pain palliation radionuclides, but it's not the most used. There is questions about the safety. And you can see also it has a really high energy, high range, and it is a bit more dangerous. It has some extra effects on the bone marrow and therefore leads to some leukemias and so forth, allegedly. So it's not, it's really a question mark, but you can use it still if you feel comfortable with it. Better options are strontium-89. These are in the chemical form of ions. We will get to that now. Then you have rhenium-168 and rhenium-188. Rhenium-188, of course, comes from a generator, and samarium. These are coupled with bisphosphonate, so they are like MDP or HDP, the technetium imaging agents. It's the exact same mechanism. Then you have some tin-177 metastable that is coupled to DTPA. Radium-223 is an alpha emitter, which is also in ion formation. And then the rest is bisphosphonates as well, of which actinium is also your alpha emitter. Some of these can be imaged. The ones in green, it's a question because that's really advanced imaging technique. So if you inject it into the patient, you cannot necessarily image the biodistribution thereof afterwards. The ones that is not in green, of course, you can always image afterwards. Yeah, so you should go back to this table and just focus on the ones that are ions and the ones that are bisphosphonate coupled. And this is what I want to discuss with you. So there's 3 mechanisms of bone, actually 4 mechanisms of bone lesion accumulation. The metabolic tracers that are FTG, we will discuss later. the ones that are cancer specific, we will also discuss later. And then there is two bone specific mechanisms called ion exchange and chemisorption. Ion exchange is where a certain ion, mostly calcium, is exchanged out of the bone matrix for iron that is in your radiopharmaceutical. There is, of course, also the hydroxy group of hydroxyapatite that can be exchanged with the negative ion of fluorine. I didn't add it here, but the F minus and the OH minus can exchange into this matrix. So it's built literally into the bone and it stays there. Or your calcium can be exchanged with a 2+ ion from all of these other groups, like your phosphorus, your strontium-89, and your radium-223. Okay. So it's an ion exchange mechanism. On the other hand, you have a more loose mechanism, which is chemisorption. So it's literally sticking onto the open calcium crystals or the hydroxyapatite on the bone. And these will be all your bisphosphonates. Bisphosphonates are coming from the traditional pharmaceutical, the non-radioactive pharmaceuticals called phosphonates or bisphosphonates that you would use for osteoporosis treatment, like alendronate, zoledronate, all of those. So it's just a phosphonate that sticks to bone. So it's a bit more loosely bound. So let's talk about diagnostic bisphosphonates. They must be stable in vivo, and therefore we use MDP and HDP currently. It's more stable than the original one that was pyrophosphate. There is some uses for pyrophosphate still, but it's traditionally not used that much anymore for bone imaging, although you can still use it if you want. So MDP and HDP, they are both the same. You can use them interchangeably. European countries use MDP, American countries use HDP, or like North American countries, but it's really depending on what's available to you. They are equal. It's very easy to label. You take a fresh pertechnetate, you add, according to the manufacturer, the amount of technetium, you mix it, it stands for 5 minutes, and you do your QC. Patient doses are up to 740 megabecquerel. The quality control you should know. Acetone, saline, the typical quality control, and then you can calculate how much colloids you have, how much pertechnetate, and how much radiopharmaceutical. The next one I want to discuss is the PET version that's come on the on the horizon recently. It's DOTA-zoledronate. So it's your bisphosphonate coupled to the DOTA chelator that takes up your gallium. It is also then going to stick on the bone. So it's just the PET version of the SPECT version. I will continuously throughout my lectures make you aware that for every SPECT tracer or technetium tracer, there is a PET version and vice versa, because nowadays all of these are available. So it was developed as a partnership for actinium and lutetium therapy. So it was viewed as a more direct theranostic partnership. But indeed, if you want to treat patients with therapeutic radiopharmaceuticals of any kind, like PSMA or the bone pain palliation agents or the MDP, the zoledronate versions or all of these, you can just use your technetium MDP to scan the patients for bone metastases to follow those metastases. So you don't need to have the gallium DOTA-zoledronate to treat the patient with lutetium DOTA-zoledronate, in my opinion. Here you can see an article that was published by the group I was involved with, and it was looking at PSMA, prostate-specific membrane antigen, which is cancer-specific, versus zoledronate versus your traditional technetium-99m scintigraphy, and the amount of lesions identified in each patient. And you will see that there's not really a clear difference. Yeah, maybe one patient you can get 20 lesions in the one scan and 5 in the other. But I think it's always important to ask, is the amount of financial spend on the patient going to change the handling of this patient? So if you have a very sensitive scan that sees hundreds of minute metastases that the other scan does not, will it actually influence the treatment of the patient? If it's going to influence how you treat the patient, yes, go for it. If it's not going to make that big a difference or change the staging of the patient, then there is no need to spend that amount of money. So you also have to be logical about it. Gallium is eluted from a generator. You buffer it to pH 3.5. You mix it, you heat it for 10 minutes at 90 degrees, and you perform QC. Here I've just added the QC that you do. It could be in the test if I ask you. And this is the mobile phase, acetyl acetone, and hydrochloric acid in 1, 10, and 10 ratio. And then you have your ITLC SG stationary phase. So very easy to label actually in the clinic. And this is the structure. You will see it's a bit different than the figure before. You can see here there is a lot of oxygens, phosphates, and hydroxy groups. And here it's only at this area. So this area binds to the bone, whereas this part is your chelator that grabs the gallium. You can also refer back to my lecture on radio labeling. So then we go into therapeutic bisphosphonates, and the most well-known is samarium-153, EDTMP, maybe not produced that much anymore, but I've labeled it myself, so it is available if you search well enough. It's also binding to hydroxyapatite crystals by this adsorption or sticking to the bone. It has a response rate of 40 to 97% within the first week, and it lasts 2 to 3 months. So the differences between these therapeutic radionuclides for bone pain palliation is the amount of time the bone pain goes away. So in some instances with strontium-89, it's maybe 6 months or more. Samarium, it is 2 to 3 months, and you can give it to the patient again. So you can do multiple injections after or treatments if there is no additional bone marrow toxicity and the patient is still eligible for treatment. There is a list of criteria, which is life expectancy, as well as the mobility of the patient and those things. They should also have bone pain, so you cannot give it to asymptomatic patients. And they should have a positive scan with bisphosphonates before you treat them. Normally within the first week, they would get a flare, which is a high pain. So you have to give them also other therapy to just reduce the pain, maybe some opioids in the beginning to just reduce this pain, but after a week, they will get pain relief. And this is really some therapy that I feel is underutilized because it gives quite good pain relief and it reduces the dependence on opioids by cancer patients and can give them really extensive quality of life. Just note, it's important that these are bone pain palliation agents. So in essence, it's not treating the cancer. It's only maybe slowing it a little bit down, but also just giving really massive pain relief. That's the most important thing. It's not for therapeutic use. And often there is no significant differences between the rate of pain palliation, the efficacy or toxicity between these agents. So all of these bisphosphonates as well as strontium chloride 89 has similar pain relief. So the differences might be in the toxicity, not the toxicity, but just maybe how often you can give it and so forth. Okay, so the figure, which is your radium-223, needs some attention on its own. So it's this radium-223 chloride that will also be incorporated into the bone lesions through ion exchange. Currently, it's the only bone pain palliation therapeutic agent that is proposed to have some effect on life expectancy, and that's an average increase of about 4 months of life expectancy. But of course, there is outliers that gets longer extended life, and then also some that is less. So it's an average of a group of patients that they tested, and you can see it's about 900 patients in total. So it's maybe an option if you feel you want to go that route. It mimics calcium, and then it is an alpha emitter. Therefore, we get the high linear energy transfer of alpha emitters with double strand DNA breakage, as well as additional effects on the tumor microenvironment. So Xofigo is a bit different than the others, and some people say it extends the life of the patient. Very important, Xofigo should not be used at the same time with cortisones. Orbitorone, acetate, prednisone, or prednisolone, it has been shown to increase the risk of fractures in the patients. Some really dangerous and very toxic, and also decreases the life expectancy of patients. They actually had to stop the clinical trial with the combination therapy. So there is a warning from the European Medicine Association: do not use Xofigo with these cortisones. It's really important. So now we jump into iron incorporation further. So it's the fluorine 18 of the sodium fluoride that is incorporated directly into the bone with ion exchange with the hydroxy minus group. So it can it is incorporated in directly altered osteoblastic activity, and then it shows also abnormal bone perfusion. It really gives nice scans. I know this is maybe, again, that thing about high resolution of PET. It shows maybe more lesions. It is better resolution and better sensitivity and selectivity compared to technetium MDP. But again, is there a difference if you see 20 lesions or 15 lesions in a patient? So I don't think many, even in the radiopharmacies here in Europe that I've seen, they will just use technetium MDP, to be honest. But it's gaining more traction and attention, and it's also a viable option, and you should know about it. It's also a nice reference that you can go and see. So the therapeutic radionuclides that work with ion exchange, phosphorus 32 is least useful due to the kinetic properties. It is really excreted quite quickly in the kidneys. It's not maybe accumulating that much where it should. Phosphorus is also distributed across the body in many tissues and not only bones, so it's a bit less targeting, and it has been suspected of inducing severe leukemia. And it is of use maybe in terminally ill patients still, if that is what you have available. Strontium-89 is much more widely used and accepted and registered. And sometimes the pain relief is lasting up to 15 months. It does have a bit of a more side effect of hematological toxicity. And then, of course, Xofigo is the alpha emitter with the modest increase in life expectancy demonstrated. Then quickly, sodium fluoride versus technetium MDP. Sodium fluoride requires a cyclotron. Technetium is available via generator systems, more costly, less expensive, of course. Also PET and SPECT. Sodium fluoride is nice for patients because there's a less waiting time. 15 minutes you can already scan, although it's normal at 30 minutes, whereas technetium MDP you have to wait like 3 hours or thereabouts. High extraction from the first pass. So when you inject it, when it circulates, the first circulation in the patient, up to 70 to 100% of sodium fluoride is already taken up in the bone and incorporated, whereas technetium, it's a bit slower. So it's only 40 to 60%. That's why you get the higher resolution. It's better accumulation, better PET, higher sensitivity and specificity. But still the jury is out whether it's worth it, basically. But if you have it available and you want to use it, for sure, go with it. Lastly, we will go into tumor-specific targeting. And these are the ones that specifically target a type of tumor. So remember that all of these cancer are metastatic cancer, and then the metastases still expresses the receptors or the characteristics of the primary tumor if they haven't de-differentiated. So if you have prostate cancer and it spreads to the bone, it will still have your prostate-specific membrane antigen target on these tumors, unless it has differentiated in a different type of cancer that has no receptor expression, and then of course it's also more aggressive. So, firstly, FDG should not be underestimated. It shows metabolic activity, and you can still see both, of course, soft tissue lesions as well as sometimes the bone lesions, depending on their characteristics. Especially of interest in osteolytic lesions that you can rather not see, or mixed. So, yeah, there is the problem of the flare phenomena. So if you treat the cancer and the cancer flare up, because it's being treated, it's some inflammation and all of that going on. It can maybe take up more FDG, or even old lesions that are treated can also show up on your FDG scans. It's also important to note that the primary tumor type has an influence on the metabolic behavior of these osteoblastic and osteolytic lesions. And there is a nice article down here, because I'm not going to act as if I'm a nuclear medicine physician, but this is the pharmacology thereof, and you should know it. Of course, the accumulation of FDG is always important to note, and this one I can ask you. In all the lectures, FDG pops up somewhere, and you should know how it works and how it accumulates. Okay, gallium PSMA, and then I put in brackets technetium PSMA, as well as all the other prostate-specific membrane antigens, because there is hundreds of them, is currently proposed as maybe the new bone scan for prostate cancer patients. So it can detect both soft tissue bone lesions as well, soft tissue lesions as well as bone lesions. It has a high accuracy and a low false positive rate, and you have the theranostic option of treating what you see and really treating it. So where your bone agents, because they normally just go stick to the surface of the bone, the therapeutic capacity is only palliative because they do not penetrate these bone lesions. Your prostate-specific membrane antigen gets internalized and often also irradiates the tumor from the inside. So it is actually treating the cancer lesions and reducing the amount of metastases. But you have to note that it's only for prostate cancer because it's prostate-specific membrane antigen. It has been shown that this specific target is expressed in other cancers, but it never was proven that it's really a viable target for other types of cancer. So unfortunately, this is what we have to do. So yeah, this one I borrowed from one of my students because she draws excellently. So this is just to show you how PSMA works. So you have a prostate-specific membrane antigen expressed at the outside of a prostate cancer cell. If your target binds, it undergoes a biological activation and gets internalized, and then it gets taken into the inside of the cell, and then you have your therapy. It radiates the cell from the inside. So this is how, with lutetium or actinium in this case, the alpha emitter, both the soft tissue lesions as well as the bone lesions are treated. So this is quite a viable treatment. And since actinium or lutetium PSMA has come on the market, the request for just bone pain palliation has reduced because, maybe you are uncomfortable with injecting both radium-223 as well as actinium PSMA in the same patient. It's really high radiation risk, and you cannot half the dose of each. You have to give the full therapeutic dose. So in my opinion, the facilities where I worked, where the prostate-specific membrane antigen therapy has been given extensively, there was a reduced need for the other bone pain palliation agents. But these can still be of use for breast cancer patients or other types of patients that cannot access PSMA because of the characteristics of the tumor. And then, of course, somewhere somebody would do combination therapy. So there is currently, in this article published in 2022, they are proposing combination therapy. So we will see how far this goes. It's with the radium-223 that is proposed to extend your life expectancy combined with lutetium PSMA, which could be really interesting. So we will see how the future goes. And yeah, I'm 4 minutes over time. Let's just stop the recording. And then this is all for today. As always, you can ask me